be able to do this. We're going to talk about the ambulatory specialty model for heart failure. As was stated, I'm Sam Jones, electrophysiologist out in Chattanooga. And I know there's always a lot of clapping for EP, so I appreciate that. Uh, this ambulatory model for heart failure is important because it is going to directly impact cardiologists in 47 different states. And I think that this is still something that many of our members are just unaware of. I would say that starting off the bat, it is not optional. It's not a pilot. It's a mandatory value-based model that's going to have real financial consequences, both real gains and real losses. And this is something that we have to prepare for. So we're trying to get this message out in the ACC. Some of you may know about it. You may have been emailed about it. But my goal is just try to make sure that everyone understands that even if you're not affected, there's a pretty good chance that someone in your group is, and you can give them some of the information. And so what we'll do tonight is just go over what the heck is the ambulatory specialty model for heart failure, and why am I wasting your Thursday evening talking about this? Next, should I care? Should my group care? And then am I on the list? And the list, I say that way because we already have over 50 cardiologists in Tennessee that are actually already designated by CMS that they are going to be part of this project. And you can't opt in, you can't opt out. Either you're on the list or you're not. So how was this list developed? How did you get on that list if you're one of the unlucky ones to do it? And then really, how can you prepare for this? And if you think that you're on the list and you're not going to be affected, just remember, CMS has ways of finding you. They're really good at that. And so let's start off with the stated goal. And that is that for many years, we want to have the volume-driven healthcare go to value-driven healthcare. So this is what CMS is trying to do, and they work with CMMI, which is the Center for Medicaid Innovation. And obviously they feel that the volume driven is going to be high cost and lower quality. And then the value driven is actually higher quality and lower cost. That's what has been said. Now, we've been told this for a while, actually. It's almost like that idea of, hey, you get free beer tomorrow, right? If you've been paying attention over time, you remember that they keep talking for the last 13 years that we are going to have value-based care. And yet it just kind of, the can gets kicked down the road. We've got a lot of efforts in the past about team models, BPCI, BPCI advanced. We've had the MIPS value pathways, but all of these were a little bit different. And I think this is the first time that it's really going to stick. They have a similar project that's going to be heart failure that affects cardiologists. There's also one for low back pain. So those are going to be the first two that actually get rolled out. And so knowing the heart failure. And so what is it? That's going to be the first thing we need to go through. It is the CMMI Innovation Center. The key words that I picked out was mandatory, 5-year project, whereas many of the other, remember that they were actually voluntary. And so this isn't mandatory compliance training like your hospital tells you and you kind of do it. No, you're going to have to do this. There's select geographic areas around the country. They went through some metropolitan service areas and they handpicked certain people, and several places in Tennessee are on that list. It's going to be comparing cardiologists. It is a direct win-win. So in other words, you're going to have cardiologists that are actually going to be bumped up in their payment, and you're going to have cardiologists that drop, and it's going to be 50-50. And so go through how they come up with that. What are they measuring? They're measuring quality plus cost. Both of those things are something that we have to understand. The quality metrics we need to understand, but really importantly is the cost metrics, because that's the one that seems to be shocking people again and again when we talk about it. And the other thing is that this is a two-sided arrangement. And by that, it means whereas voluntary models, yeah, you may win, and that's good. You're not going to really get much of a penalty. This is actually going to be two-sided. You can go up to 9% of your Medicare Part B or lose 9% of your Medicare Part B. And so a true two-sided risk. And other models over time, they started off low and then kind of tweaked it around. This one right off the bat is going to model. And so say that it is like a bundle, but for heart failure. So we've had bundles for many other things before in the past. You can remember other advanced payment models where they've had BPCI. These were bundled payments, and BPCI advanced that they did later. from 2013 to 2018, and they kept rolling these out. This would have been for some sort of episode. It could have been if you're getting PCI, heart failure, CABG. All of those were the original steps to get to where we are now. But those were all voluntary. And so many people jumped on some of the BPCI advanced, and they may have done it for CABG. And then they didn't like the way it was getting recorded because some of the cost measures may have been attributed to them that they had no control over it. So over time, it seemed like much of that went down. And the other thing is that they really didn't save the government money at all. And they think it's because it wasn't mandatory. And only the people who were actually doing it, the people that knew that they were going to win. So they said from now on, they're going to go away from any of these voluntary. You have to do it. If you're picked, you're going to do it. And they're going to do it for low back pain. And just remember, that's just the first. They're going to go then, I suspect, into atrial fibrillation. That's going to be a good one. They'll probably do chronic kidney disease, COPD, angina. They're talking about a lot of these models. We just happen to be in the first two. So when you think about it, I would say think about your entire heart failure population. That's the procedure. And we need to understand how that comes from. The timeline's pretty important. And so if you look at this, November of 2025, they came up with this proposal, and they asked for a lot of comments. And I'll tell you about some of the things American College of Cardiology actually mentioned to them. And some of that they took under advisement, and others, it was just, thank you for your viewpoint, we're going on. In early of 2026, they had the preliminary list of participants. These are the people who are actually going to be affected by this. And again, it's selected geographic areas. And so from ACC, we started outreaching. Now, there's still some issue with that list. So it's going to be finalized in the summer. They're not going to add anyone on. They may take some people off. And then what you'll see in January of 2027, that's when the performance period begins, January of 2027. The payment adjustment always follows 2 years from that. And you don't really know what happens during that 2 years. So January of 2029 is when you'll get that. And this is, I put the red arrow there. This will be probably somewhere around 2030. And it's going to be interesting if you had any idea what happens at that time. And that's going to be when you probably finally understand the program, because there may be some tweaks to it. We're not going to quite understand. We're not going to understand the cost measures. And so my personal belief is it's going to take a while before you even understand it. And those people are already in it. The best thing we can do is to really start getting ahead of this as much as possible, because as I've said, the timeline is ticking. There's less than 8 months to prepare right now. And if you're on that list, it's really important to start thinking about what does my group need to do, and how am I going to make sure that I'm not one of those that ends up losing some payment on this. All right, so we talked about what it was. We talked a little bit about the timeline that we have, which I think is critical. It's going to sneak up on us very fast. So who is in it and who's not in it? The first thing I will say is for heart failure, it's going to be cardiology specialty. So they're not going to be taking internal medicine doctors, any primary care. None of those are actually selected. You have to have a PCOS code of cardiology. Now, if you actually are identified as interventional cardiology, you're excluded. If you're identified as advanced heart failure, you're excluded. So even though it's a heart failure bundle, advanced heart failure is not. And the reason is because they felt that many of the patients who see advanced heart failure are going to have enormous costs, right? They're going to have all of the things that advanced heart failure has between LVADs and some of the other things that go along with that. And they felt that that may be a skewed population, and it won't be fair to have advanced heart failure. Likewise, my specialty, electrophysiology, they're not going to be in it either, probably because they feel if we're seeing it, it's skewed toward defibrillators, CRTDs, and actually some atrial fibrillation ablation and other things that may happen there. So those aren't going to be there. And then all this is based upon your PCOS code. Many of you know your NPI number, and your NPI number is with you for life. That never changes. But your PCOS code can change depending on who's put that in. That's what's supposed to say you were cardiology or you were internal medicine. Now you're in interventional cardiology or your heart failure. That one can change. It also can be tied to where you are. So that's who is even allowed to be in it. Now, not all cardiologists, because it's only in certain areas. In other words, they picked some major geographical codes, and Memphis is definitely in there. Nashville is in there. Chattanooga is in there. Knoxville. And they said, at least you have to be in there. So if you're in a smaller town, they weren't going to take that because they thought that might be a skewed population. So only of those that they expect, and probably about 20% of cardiologists across the nation, or they thought would be involved in it. The other thing is that you have to see at least 20 Medicare heart failure patients. And so if you're a cardiologist who's doing other things and you're not seeing Medicare heart failure patients, maybe you wouldn't get that. And so that's something too. And how are they going to know that? They're going to look at claims-based data to look back and say, okay, have you seen 20? And can we show that with some heart failure medications? Did you claim that you saw systolic heart failure? And if you did, then that's going to be it. So overall, it's not going to be everyone, but certain areas and 47 states right now. And could you voluntarily get in the geographic selection? Nope. They came up with it, and they're the ones who said that you're going to be in or you're not. All right, so that's who could be in it. And toward the end of the presentation, I'm actually going to have a list of all Tennessee cardiologists because I went through and picked apart to make sure I could find out who is in it. And because it's public data out there, anyone should be able to get that. So in the heart failure performance assessment, the main two things are quality and cost, which again sounds really easy when you say it fast, but we need to understand what those qualities are. I usually think if I can't explain something without using Homer Simpson, I probably don't understand it really well. So as he says, trying is the first step towards failure. But we're not going to do that. We're not going to have the failure. We're going to have people understanding what it is. 50-50 quality and cost. This is kind of like already the MIPS programs that many of you are in through your ACO, through your hospital. And the important thing here, though, is they also have these improvement activities and promoting interoperability conditions. You don't get extra points for that, but if you're not in those, then they'll get reduced. And we'll talk a little bit about how actually they came with that. But it's important to understand it's whole person accountability, not just your office visit, but every cost that'll go. And we need to kind of break that down a little bit so that we understand that. So what are they trying to do? They're trying to keep patients out of the hospital. They think it's better for patient care, and they think is extraordinarily costly. And there's no doubt that they picked heart failure because the amount of spend that Medicare does on heart failure, astronomical. And private payers feel the same way. So they want to keep patients out of the hospital. They want to use GDMT. And they want to actually say, all those things are good that you told us, but we want you to start looking at patient-reported outcome measures. We really want you to measure patient symptoms because that's not something that we've been doing over time. So that's what they're hoping to. The problem is, as they are measuring us in that, you won't know from 2027 until 2029, based upon their metrics, how you're doing until that payment's adjusted. So it might be something that you need to start thinking about. How do I look at my quality? What are some of the things that I can do or my ACO can help me with to make sure that I have some sort of idea and I'm not surprised with it? So when they say use GDMT and keep patients out of the hospital, these are the quality measures. Now, some of these are already used in some of the other MIPS categories. You may remember MIPS is one of those quality improvement programs that CMS has. And you can report a lot of different MIPS if you want to. Of these, many of you are using some of these, some of you are not. But these are the ones: unplanned cardiovascular admissions in patients with heart failure. You remember before they've done heart failure readmission programs to try to reduce that, with some admitted issues with that because they found that people were just keeping patients out of the hospital when perhaps they should have been admitted. So there may be a downside to that, but that will be in there. The other things are what you would suspect for heart failure: beta blockers and either ACE, ARB, or ARNI if they have left ventricular systolic dysfunction. Controlling high blood pressure. This will be fairly easy because if you're in MIPS or not, you're probably already reporting this one. And then this is going to be the real biggie. MIPS number 3775, getting a functional status assessment for heart failure. And I could ask you how many of you are doing it, and I suspect most of you are not. Most of your hospitals are not. And there's two of those that are appropriate, which is the Kansas City Cardiomyopathy Questionnaire or the Minnesota Living with Heart Failure Questionnaire. If you don't have it, it's encouraged that you start thinking about getting that because it takes a while. You have to go to the website, and there is a cost associated with that in order to get it. It depends on what the volume status is. So this validated patient-reported outcome tool, there may be a bunch out there, but these are the actual two that they want you to use. All right, so this is kind of fun to think about. Already, I mentioned that some of you are reporting things. These are the common MIPS that people are reporting right now. This is what your cardiologists are being reported on. Breast cancer screening, no joke. Because you're in an accountable care organization, many of us across Tennessee, we will fall into the bundle of the ACO. And if there's breast cancer screening, fall risk screening, we sort of fall under that ACO. But what they're trying to do is say cardiologists shouldn't be really looking at things like breast cancer screening or the following or colorectal cancer screening. We need to pull them out more. And so two of the ones that are probably being looked at already are some of the hospital admissions and controlling blood pressure. You're probably already being part of that in your ACO if you are. So this is pretty interesting though. Think about the quality measure participation overall. Right now in MIPS across the nation, of our 35,000 cardiologists we have, about 15,000 that are not EPs, interventional cardiology, and others that are actually being measured. If you look at this, you can see that we're not actually having a big participation in a lot of these. Controlling high blood pressure, yes, that one about 10,000. So over 2/3 of the people are actually in that one. But if you look at who is actually reporting, are they on an ACE, ARB, or ARNI? It's actually less than 8% right now. Same thing for beta blocker, which should be low-hanging fruit, but some of the quality participants find it hard to actually do, and they get worried that the exemptions for someone who can't take an ACE inhibitor because of an allergy or renal dysfunction or others don't actually get adequately assessed, and therefore they're getting penalized for it. So people have been a little bit leery of that. Again, that's going to be two of the main ones. And yet right now, we just don't have many of our cardiologists actually even getting looked at for that. But there's another one that's really important. And that is, let's focus on that functional status for heart failure. Out of over 15,000 general cardiologists that are being assessed right now, what is the number that actually are using one of those and then they're telling CMS about it? Now, the other people are using, especially for research and others. But for day-to-day practice, those that are reporting it back to CMS, 8 out of 15,000. And so I do think that we have a lot of work to do there to make sure that you're actually utilizing those tools, not just for research purposes, but somehow it's going into the overall chart for the patient. So that's some of the quality metrics. You would probably have thought that beta blocker, ACE inhibitors, the patient reported outcomes may be something that threw you for a little bit of a loop. Now I'm going to throw you for a little bit more of a loop, and that is the cost measure. 50% is based upon this. So this is cost of all of those patients that are assigned to you if you're in one of the few that are taken. And what is the cost? Well, basically it's all cost, right? If they get to the anything going to the emergency department for heart failure, it could even be in another state. So while you're asleep at 2 a.m., they're off in Kentucky and they get admitted, and you're going to get that cost that's attributed back to you. All cost inpatient, anything surgical that they can tie to heart failure. If there's post-acute care, if they go to a SNF, a 30-day window after a admission, that would be accounted to that person. Ambulatory and outpatient care, the clinician services. And then the big one is that last one that you see at the very bottom, which is the Medicare cover services, not just durable medical equipment, but Part D drugs, because the drug cost on your patients that are on their SGLT2, that are on Entresto, that's fairly substantial. And that's going to actually be attributed to this. You know, it's interesting when they looked at cost a few years ago, they tried to say across the board, who was the highest cost cardiologist in any group. And most groups had what my group was. I pulled the cost data, and I was one of the highest costs, and that was because of the defibrillator and the other things that we put in. And they said per patient, I was costing them way too much, but that's because it was skewed. But the other thing they found was the patients who are actually on the highest cost medications were skewing it very high as well. And so they still left it in though. And that's one of the comments that we made. And so I think you need to have visibility into what your patients are doing, not within your clinic visits and not just within the medications that you're providing and other services, but even to the emergency department, to others. And this is CMS's way to try to say somebody needs to be responsible for all this. And just when they're outside of the walls of your clinic, then you need to think about that. And if it's going to be rehab, make sure that it's really worth the cost of that to you. And so that's going to be a huge issue for a lot of our providers. All right, so We mentioned who's going to be, how did they select it, what are the quality measures, and what's the cost. And I think right now, if you're thinking about how am I going to prepare, the first thing I would say is look at the quality measures submissions, because you may not know about this until 2 years after the fact. So probably start thinking about, do I want to do this myself? Maybe your MIPS administrator, if you're an ACO, they may actually have this already. They will have shadow bundles where they look at your quality, but also shadow bundles where they look at the cost. And so there may be some ideas that you can get from them about what your cost and quality is. And also make sure that they're able to collect and submit all of these things through the EMR. A lot of people are wanting to make sure that their patient reported outcomes, the Kansas City questionnaire, is in the EMR. And as of yet, we haven't quite been able to ensure that that's the case, but that would be something that would be very helpful. And so those that are already following you for your breast cancer screenings, the people in your hospital that are responsible for this, I would make sure they know we're going to have a patient reported outcome questionnaire that we need to make sure that's there. And then probably your highest risk patients are going to be those with unplanned readmission measures. And so those that are really employed by a facility and you have some ability to change that, you may want to say, like, let's think about what can we do to try to keep them out of the ER? Or if they're in the ER, what can we do to have rapid transition back to our clinic so that they don't have to be admitted? And there's a whole host of things that you can do for that to kind of prepare. That could be using some other tools in remote patient monitoring. But a lot of it is trying to get your hand around those hospitalizations and decide, how am I going to actually be able to get rid of that, or at least get it as much as possible? And who are the patients maybe I need to focus on the most? And so the final score, as I said, quality and cost, 50% each. Improvement activities and promoting interoperability, you get subtracted if you don't do that. Those are just the things that are basically asking about, are you doing something with your primary care? Most of you, again, if you're an ACO or part of an employed hospital, you probably are doing this. If you're a private practice, this one's going to be a little bit tougher. But you have to make sure that you're having some mechanism of going back to the primary care and having an interoperability issue. And on electronic medical records, certainly there are ways to do that. So what is the payment approach? I mentioned this some before, and this is up to positive 9% on all of your Medicare Part B payments, on all of your Medicare Part B payments. So not those attributed to this patient population of heart failure, but to all of your Medicare Part B payments. Or it could be negative 9%. So we're going to have 50% of cardiologists that are going to get a positive adjustment, and they may get 1, 2, 3, 4, up to 9%. And we have 50% that are not. That's also different about this, because before it's been paid for through other mechanisms. This is supposed to be exactly budget neutral. We're going to reduce this group of cardiologists, and we're going to give it to this group of cardiologists, thus the two-sided risk that you actually have to have. And so it would be a shame to get to the end of that 2-year time in 2029 and have no idea what's going to do and realize you were one of the ones that had a negative 7%. Even if you did everything right, even if you were treating your patients well, doing everything optimal, and yet it wasn't documented right, or the person in charge of your quality control didn't do that. Because it's actually going to get more than that. They said they're going to probably increase it 1% in years 3 through 5. It's going to be a 5-year total project, so up to 12% by the end. So then we're starting to talk about real money here. One of the things I did want to talk about was the ACC and some of the concerns that we had. So when they rolled this out, they usually have a comment period. And we worked with a lot in our quality people within ACC, our heart failure groups, to say, what are some of the issue? And the number one thing that came back was attribution. And the attribution is, in this model, individual level focus. In other words, it's going to be tied directly to your PCOS and NPI. That's going to be the one to that cardiologist. And yet, this is not what we try to do in cardiology. We actually try to have a team-based sport, right? We have our advanced practice practitioners who are helping us. And all of those things that may be done with other people will be attributed to this practitioner. And I think that's a little bit unfair. It should probably be at the 10 level, your tax identification number. That's what other quality projects have done. And that may be better to say, all right, in our tax ID that we're doing with all of our nurse practitioners, with all of the other cardiologists and EP and structural heart, this is how we're going to manage this patient, rather than attributing it to one single person. It's just not how Medicare care is practiced. So that's a concern. And also real-time patient attribution. You'll be nice to know this patient's there and I'm getting some of the quality measures I'm not doing well. You may not know that if you don't measure it yourself until 2029 when you get that. So that delay is not good. That's not how quality programs should work. There's also some operational design flaws that could limit the effectiveness. In other words, if you're doing some very high cost medications, could that come back to bite you? Other issues, the patient reported outcome. That's a license and that's required. So you actually have to make sure that you get that. That's a little bit extra burden and it's a little bit extra cost that most of us were not prepared for. And there's an immediate downside risk. So 2029, you may lose it already, and there was no ability to know what's happened. There was no transition for it. So the timeliness of the data, we think, is really something. So we're going to keep sharing this data. Maybe they'll be able to adjust it as we go on. I think it is possible, but this is really where we are. I promised you I'd have a list of all the cardiologists involved with it. And so, again, this is public information. And so I was able to pull all of these. And what I did was most of this is alphabetical by the organization that they are in. And so these are the cardiologists, and there's going to be a second slide that goes through this as well with other cardiologists that have already been identified as CMS. You will be responsible for this. As you look through this list, you're going to see something pretty interesting if you know any of these people, and that is they are not all solely cardiologists without another PCOS code. Some of these are actually interventional cardiologists. So that's a problem. And this is where we have gone back to them and said, you said you were not going to have interventional cardiologists or electrophysiologists or you heart failure practitioners on there, but you do. And so they're going back. It turns out some of those actually, the hospital has them not listed as interventional cardiology. The hospital has them listed under cardiology alone, and therefore they're not going to be excluded. If that person is in your group and you feel like that's good, you may say, actually, that would be really good. We'd like to have it. I think most people are trying to opt out of it. So that's something to think about. But this spanned Tennessee from Knoxville, Chattanooga, on through Nashville, and then on into Memphis, as you saw. So a lot of information. I'd be happy to take questions here in a bit, but I would say the three things is number one, it's mandatory and it's real this time. And this is something they've been telling us now for years and years and years. But I think this one is really going to go through. All indications are they're not taking any more comments up until they start it in January of 2027. I think that you own your total heart failure cost. And so what that means is you probably will start thinking about things that are happening outside the walls there and everyone who's there a little bit more if you're part of this. And if you're not part of this, I would tell you, they may roll it out again. When they said 20% of cardiologists, it may go to 40%, 60% over time because they have been very adamant. They want to put everyone into these kind of models. So coordination with your primary care is critical. And this you have to make sure that your practices are ready for this. Make sure that you understand if you have an ability for heart failure management through the ER. What are the things that you can do? Now, what's interesting is that some physicians may see 21 patients and therefore they get into the program one year and the next one they have 19. They may toggle in and out, and that's going to be something that's interesting. But attribution follows that specific one that gets tagged with it. It's not going to follow anyone else, and I think that's critical too. I had a readiness checklist just to look at, and I would say that if you have an implementation team with your group, that can be helpful. You got to have the quality administrators though, and you got to have the staff because they are often the one that are going to be looking at this. The claims-based data is where they're going to decide who actually is involved and which patients. But after that, it needs to actually be reported through your quality administration department. And then if you know who the cardiologists are and what your practice level plan is, I think that's important. The third there is, see, can you actually submit some of this via your EMR? Because that will be helpful rather than having to do it more manual. And look at your ACO already. It turns out they are probably already looking at you in this. It's sometimes shocking to find out what people are testing us on, and we don't even know. It may actually have some shadow cost data for you, especially for heart failure, because this is something that ACOs are wanting to determine. And then, as I said, you have to have an action plan for implementing your functional status tool, your Minnesota Living with Heart Failure, Kansas City Cardiomyopathy Questionnaire. You can't wait to the very end because these are licenses that you have to have, and you can't get them right away. So I think that's really important. And then, as I mentioned, the improvement activities, this is going to be some social needs screening, Many of this should be able to be reported through your primary care. Heart failure, I mean, the cardiologist can do it for those heart failure patients. But if you have a way to connect it and it's already been reported there, then that's good. And also showing that you have it. Many of these are more attestation issues than anything else. I think that's also true of the heart failure questionnaire because a lot of those patients are, what am I doing with this? I'm just submitting it. Are you even following it? It would be good ideally if we did, but we want to hear that patient voice. But at this point, the requirement is just to make sure that you have it. And for many people, that's it. ACC has a lot of data on this. And if you go to the ACC advocacy website, you can see the educational tools for heart failure and how they determine the mandatory geographic areas. If you have questions, submit it. Our AC staff are the best in the business, and they're happy to look into something if it's something we haven't thought of already, and that can be it. All right, that is what I had for that. There's a couple of background slides, but I thought this would be a good place to end, and I'd be happy to answer any questions about this model. And if I don't have the answer, I'll find someone who can.
Thank you, Sam. That is fantastic, but at the same time, very scary. You mentioned that the 9% up or down applies to the entire practice model, not just heart
Yeah.
failure. Is that correct?
Not just heart failure. Yeah. This is what we're being told. And I think we've asked that question 30 times in 20 different ways. It is all Medicare Part B spend, all Medicare payments Part B that you're getting should be affected by that. And so that is, substantial. Now, many of, if you're employed with your hospital, to be honest, that will actually go more to the hospital than it will to you, but it will come back to bite you when you go to renegotiate your contract. That may be years down the line, but if you are losing them that portion, then they're going to say, oh, just remember, this is why we're going to establish your RVU cost per RVU at this level because we were losing some money here.
Sam, do you anticipate there will be organizations that can provide service educating all the physicians in the practice model, and perhaps it's a combined team effort to comply with it because this will affect all of us?
Yeah. Yeah, I think so. I think I know that MedAxiom, if any of you are part of MedAxiom, it's a great organization and they're doing a lot of education. They also have ways to help. MedAxiom is the business side of cardiology and they work solely with cardiologists. And I think that is probably the biggest one that I know of. But undoubtedly, I think once other organizations start realizing that the cardiologists are still hit with what the heck is going on here, then they will be trying to find a way to help for a fee, right? As for a fee, but that is true, I'm sure. Yeah, but great question. It's every time I've heard of one of these before, I thought probably not going to actually go through, but this one, this administration, when they put their mind to it, this one, and then there's no indication that they are slowing down with how they're going to do this. I think it's going to be fascinating to see what happens. Do they affect all cardiologists eventually? Do they expand the pool? I really do think that atrial fibrillation and some of the others are going to be closely following it because to date, all their efforts for ambulatory, for the advanced payment models just haven't really worked yet. So they're really trying to find something. The only one that worked was orthopedics. And that's because there was a reduction in spend when the orthopedics just said, we can start doing the hips and then sending them home and we won't send them to SNFs in some places like that. So essentially, it was just a rerouting of the money and it saved the government some money that way. And there was less rehab and SNFs that happened. But I think most of the others have not really been as effective as that they were hoping.
Fantastic. I can see that non-heart failure doctors will stop treating heart failure patients, and many of our frequent flyers patients will be dumped from practices because this is I can see right from the get-go that the patients will suffer because we will not be using expensive medicines, and if you are admitted twice a year, you will be let go from the practice.
Yeah,
Um,
I think that's the worry, right? We've seen that in other places when New York instituted their quality measures for surgeons and they started tracking mortality rate, and it was not well risk adjusted. What we saw was that surgeons just stopped operating on anyone that was high risk because they didn't want to affect their mortality numbers. And so there's always a downside when you do this. And similarly, as you're saying, when they first came out with this a few years ago, where there was no teeth to it, but they said we're just starting to look, it became quite obvious that if you wanted to treat heart failure patient with some Lasix, lisinopril, some carvedilol, and spironolactone, and some digoxin, you were going to win on that cost measure. If you wanted to add in Entresto, your SGLT2s, you weren't going to. So I think that's one of the issues with the cost measure. Now, admittedly, they say, but cardiologists, you tell us that keeps people out of the hospital. That's what you tell us. And so let's see it. You're going to use those medications and you're going to earn it back on less ER visits, less unplanned CV hospitalizations. And so we want to see, is all these things that you're saying really true? So it is an interesting conundrum, and it depends on the timeline in which you look at that. You know, they can look at an electrophysiologist, which they're not in this model, but in others and say that ICD was extremely expensive. In the first 5 years, there was no difference. I say, yeah, but give me some time and I'll show a mortality benefit, long term. So I think that how you look at over the time horizon is going to be something important too. And at least this is 5 years that they're looking at. So if you have someone on a really good heart failure regimen, you would hope that in a 5 year you'd see some improvement in their clinical status. But we have to follow this closely. I see Doug's, if he's still on the line, you've been through a lot of these
I
in the
am.
past, Doug. I mean, you've seen these come and go. What do you think about this?
Well, I think exactly as you're saying. I mean, the devil's always in the details. And as you've said, so many of these really have been fruitless. But the problem is, you know, I'm not sure. I don't know why they don't have you or us really planning this stuff for them. I mean, we know the patients, we know the costs, we know the process. Um, so, I mean, what they should come to MedAxiom or ACC and say, okay, let's work as partners and figure out the best way to do this. But it doesn't sound like that was the case.
Yeah, I think that's a great point. It's like so many other things you deal with, like prior authorizations. You're like, well, why are you telling me what to do? And I can actually literally hear you Googling what atrial fibrillation is, or you're putting on your chat GPT and you're saying, no, they don't need an ablation. Have you thought about beta blockers? Oh God, guess what? I've thought about beta blockers for that. And
It's
so
crazy.
you're right. I think it's just a constant theme that you have across medicine right now that people who don't understand couldn't tell you there's four chambers of the heart, and yet they're making some decisions on this. Yeah, that's frustrating. I do think that ACC, MedAxiom, we do a great job of trying to. We know we can't run it for them, but we try to influence as much as possible. And I think that the more is one of the great things that our societies do. And because if we weren't there at all, it would be much worse, I fear.
For sure. But, and so just another final comment. I mean, who has more data on this kind of stuff than we do, than the ACC? No, I don't know of any other organization that has the kind of cost and outcome data when you throw in MedAxiom with us, which is part of us, that we do. So it's not like, they're just going to some rinky-dink organization. I mean, we've got more data than the feds do, I bet. I mean,
Yeah,
first off, they're just using, billing data anyway, our cost
yeah, it
data.
is. Claims-based data has a lot of
So there
issues
you
with
go.
it,
That's the
and
word I
yeah,
was looking
yeah,
for. One other thought, and then I'm going to go myself. But as we know, the Medicare Disadvantage plans are doing the same thing that Farik just said. They're basically looking at, okay, you've had a whole lot of visits to the ED. We're not going to re-up you next year or whatever, or we jack up your rates, or we don't want them as part of our patient panel. I mean, they're all over this.
yeah, yeah,
So, um,
absolutely.
well, good to see you guys. And, I'm still glad to be mostly out of it, but I'm still interested, obviously, or I wouldn't be here. So you all take care. Betsy, you too. Thank you, Doug. Thank you, Sam. You've been extremely gracious with your time. This was very informative for all of us. I think we would love to have access to your slides so that this program can be, retailed to some of the important practices. But I appreciate your time. Thank you very much for your effort.
Yeah,
Thank
Sam,
you.
wonderful as always.
Thank you so much. If I can be of any help, let me know. Great to
Thank
see
you.
Thank you,
everybody.
Sam.
Have a great Thursday. Yeah, thanks,
Thank
Dylan.
you.
Thank you.